All right, so we will start with, what did I decide on? Respiratory modalities. Where's my share? All right, so we'll start with respiratory modalities, go through concepts, and then finish up with chest injuries, surgery, all that fun stuff, chest tubes. All right, so respiratory care modalities. So first, oxygen. We know that room air is right around 21%. And then it goes up from there. Every liter that you get an additional 4% of oxygen. But of course, the goal with our oxygen therapy is to provide adequate transport of oxygen in the blood while decreasing the work of breathing and reducing stress on the myocardium. Manifestations of hypoxemia, changes in mental status, so restlessness, those changes sometimes you often see start to be those first signs of hypoxia. Then as it progresses, you have your dyspnea, changes in vital signs, increase in blood pressure, heart rate, dysrhythmias because the heart's not getting enough oxygen. Central cyanosis then, of course, would be a later sign. And diaphoresis, cool extremities, all signs that the body is not getting enough oxygenation. And then on the other side, we have oxygen toxicity. Oxygen toxicity occurs when there's greater than 50% of oxygen is being administered for longer than 48 hours. It can happen sooner than that as well. But we've mentioned before when we talked about cardiac, like with MONA, the whole morphine, oxygen, nitro, aspirin, the oxygen isn't necessarily mandatory anymore because of this oxygen toxicity. We don't, if your patient is satting decently, even if they are short of breath or having respiratory difficulties, if their oxygen saturation is still at least above 92, 94, we don't want to give them too much oxygen and cause oxygen toxicity because there's just becomes that overproduction of those free radicals and can start to damage the cells. So signs and symptoms of oxygen toxicity then, non-productive cough, restlessness, substernal pain, nasal stuffiness, nausea, vomiting, fatigue, headache, sore throat, dyspnea, and hypoventilation. Especially, we know that our COPD patients are at risk for a decreased respiratory drive when you administer too much oxygen and they continue to retain CO2. Which, by the way, I did forget to mention that. So there's that COPD PowerPoint. It's just a review, should be a review from 110. But when we talk about different respiratory concepts and everything, just refamiliarize yourself with COPD because we'll touch on it here and there, but I'm not going to go over COPD in depth. So as far as this test is concerned with COPD, it's more in relation to the concepts that we're going to talk about. So anyway, so with our COPD patients, they don't have the normal, because of the CO2, the chronic CO2 retention that they have, the brain uses those central chemoreceptors in the brain to tell the lungs what to do, whether to hyperventilate or hypoventilate if those CO2 levels get to be too high. Well, that doesn't happen with COPD patients anymore because it just gets like desensitized. So instead of CO2 being that mediator to tell the body what to do, it now goes to the oxygen peripheral receptors as far as the oxygen concentration. So the higher the oxygen level, then it's the brain is going to tell the respiratory status to like slow down. So that's where why it's important not to give those COPD patients too much oxygen because they don't have that normal process. So then they will decrease their respiratory drive if they have too much oxygen, despite having those higher CO2 levels that they really still need to be blowing off some of that CO2 and still need to hyperventilate. So they just don't have, that's why we have to just be careful with our COPD patients and administering them too much oxygen. So that Venturi Mask, we'll talk about the different deliveries here in a second, is the best option for some of our COPDers because it gives a more precise level of oxygen delivery as opposed to like a bigger range of oxygen, so they could get too much. So then we also have combustion. We know that oxygen has that danger of fire. Should never be smoking with oxygen, although we know people do, and then they wind up in the burn unit. So the different devices, we have our nasal cannula, our simple face mask, Venturi mask or the Veni mask, partial rebreather, and non-rebreather. So here is our nasal cannula. Pretty sure he's not getting any oxygen right there. But anywhere from 1 to 6 liters, typically with our nasal cannula. If you're going above 6 liters, then you should be switching to some type of mask. So as I mentioned, we know that our room air is right around 21%. That's an average, give or take 21%. But then when you add each additional liter, you're adding an additional 4%. So it's not exact clearly, but I think the idea is that it's easier to remember even numbers. So when someone is on 1 liter, they're receiving 24%. So technically, if you go by 21% for room air, add 4 liters, yes, it would be 25%. But again, I think it's just a matter of that they go by even numbers. So 1 liter is 24%. And then each additional liter would be another 4%. So when you go all the way up to 5 liters, that patient's on 40%, 6 liters, 44%. So it's a simple math equation. I know I put oxygen concentration on the math section, but literally that's all you have to do. How many ever liters they're on times 4%, it's that amount plus room air. But just be careful that technically we're going to start at 20%, not 21%. For our calculation. So the advantage of nasal cannula over masks, it's less frightening. They can still eat, drink, talk. It's not as cumbersome to wear a nasal cannula as it is for a mask. But it does have disadvantages of nasal drying. So we know that we have those humidifiers that we can put with our nasal cannula. So that way it just gives them that little bit extra moisture so it doesn't dry them out too much. And we have our simple face mask. This can be anywhere from 40 to 60% FiO2 with a flow rate of 5 to 8 liters. The advantage is it is a higher amount of oxygen administration that we can give. Disadvantages, just the things that go along with having a mask on your face. It can be more frightening for a patient since it is covering their face and harder, can't eat and drink as easily and talking and all those things. But you do need a flow rate of at least 5 liters or higher if they do have a mask on, because otherwise that CO2 can be retained in the mask. So you want at least 5 liters or higher so that way it flushes some of that expelled CO2. Then we have our Venturi mask or a Veni mask. Can be anywhere from 24 to 55% with flow rates of 4 to 10 liters. So as I already mentioned, the Veni mask is nice because it delivers a more accurate flow. So it's beneficial for those patients that we need to be careful with giving too much oxygen, like our COPDers. Same disadvantages of any mask, of our simple mask or any. So it depends on where you're at, what type of mask you have. But so this one here, you can see that there's like a dial on the side that you can change it to whatever exact percentage it is that you want to administer for your patient. And then it'll also tell you how many liters they need to be, you need to adjust your flow meter for in order to get that percent of oxygen delivery. So this, do we
do this, or does respiratory do this?
We can do this. We can do this. I mean, you can get input from respiratory, and if you're not familiar with it, but it is something that if you have an order, from the physician that says titrate oxygen to keep SATs greater than 92%, we can use any of these methods for our patient in order for them to obtain that, especially if they're in any distress or anything. So this one is an example of one that we turn the dial. At least I know the ones at Lutheran. I don't know what ones they have at Parkview. They have more like a color-coded system where you take that whole piece out. So like you might have 5 pieces to get those different percentages. And on that color, that different color piece, it'll tell you how many liters and what percent they'll be getting when you change it out. So you change that part that's green in here, you just take that whole thing out and put whatever color it is you need. So the dial ones are obviously a lot more user friendly because you don't have to take things apart and put it back together if you need to go up on your oxygen or anything. It's much more simple, but there's just different types out there.
So we as nurses can choose, okay, so they're not getting enough oxygen with the simple mask, we need to bump it up to Venturi.
Yeah, I mean, technically, I mean, it's non-invasive, and I mean, even if you don't have an order for oxygen, you're not gonna like sit there and let your patients like be in the 70s while you're waiting for your doctor to call and give you an official order. But I mean, it's pretty much a standing order, you know, that the patients can have oxygen to, you know, keep their O2 stats where they need to be. But yeah, I mean, you can titrate. I mean, it's just a simple, there's still, just because it's a different delivery, they're still getting oxygen, and the oxygen is the main order is that they need oxygen. And yeah, I mean, when it has to be, you know, because you got to charge patients for everything. So even if you don't have an official order in the computer, it does need to get in there just, you know, for legality purposes. But yep, you can titrate it up. Now, if they get to the point where they need something like Bipap, that's a little bit different. That does need to have specific parameters and an order from a physician, and respiratory would have to initiate that. But just as far as, you know, different masks, that is definitely within our scope. And then this is a partial rebreather mask. So a partial rebreather and a non-rebreather are literally the same exact mask. The only difference is this spot right here. So you can see here that on a partial rebreather, there's not a valve right here. And then on this non-rebreather, there's that little valve. It's a one-way valve, so it helps. So with the non-rebreathers as opposed to the partial rebreathers, the non-rebreathers administers more oxygen because it doesn't like escape through that little port there. So your partial rebreathers can be anywhere from 70 to 90%. It's got that reservoir bag, and that needs to be, you have to make sure that that is filling up, because it should be filled at least 2/3 or so full in order for them to be receiving that oxygen. So what they do with that reservoir bag, they rebreathe 1/3 of the exhaled tidal volume, which is then really high in oxygen concentration. So they get that higher level, that 70 to 90%. Same disadvantages as any mask. And then your non-rebreather, again, since it's got that little one-way valve, they get almost 100% oxygen when they inspire. When you get these new out of the bag, you really need to make sure that, because those bags sometimes kind of like stick together, like because they're like folded up and they stick together. So you sometimes need to like kind of, it's not a seal, but kind of just like move it around so that way it does start to fill up, because it's not going to do its job if you don't allow that reservoir bag to fill up, so that way they can get that nearly 100% oxygen. So if you need to give if you want to start with the partial rebreathers, literally the only difference is that valve. So you won't like see a specific partial rebreather bag. Literally all you do is you grab the non-rebreather mask and take that valve off, and that's all you do. That's the only difference. Our non-rebreathers, since they are getting almost 100% oxygen, it's usually more so our patients that are in severe distress. Again, back to that oxygen toxicity, you just really don't want to be giving 100% oxygen any longer than you have to. So if they're in severe distress and they're maybe getting ready to be intubated or something like that, you might be getting them on this 100% non-rebreather. But other than that, you don't just want to routinely put someone on a non-rebreather mask for a very long period of time, because you definitely want to be troubleshooting and figure out why their oxygen is why they are desatting so much. All right, then we have our OPAs, our oral pharyngeal airways. You're going to see these more so maybe like in the ER setting or pre-post-op, not so much in your normal inpatient setting, because these are definitely very temporary airways. to facilitate, opening the airway. It's not like a tube that's going to help them necessarily breathe or anything, but someone who has had sedation for a procedure or something that's overly sedated and just having a hard time keeping their airway open, these OPAs might be placed in order just to facilitate that, but they're not going to be in very long term. So again, maybe someone that comes in the ER that's having difficulty breathing and they're unresponsive or something, they might put these in, because it essentially just you measure it from the mouth to the ear and you put them in, and it's essentially just kind of opens up that airway, gets the tongue out of the way and stuff, just to try and get them to be able to breathe a little bit better. So that is one temporary, very, very temporary option. But what we're mainly going to focus on today is our endotracheal tubes, our oral ET tubes. This is what we place for patients in respiratory distress, and it needs to be placed by a physician. And what they usually use is a laryngoscope in order to visualize the airway and get the tube down in. And then they can be mechanically ventilated, obviously surgeries, whatever the case may be. But this is where they definitely need that mechanical ventilation or something. So our ET tubes, again, it's used for mechanical ventilation, usually right around 7 to 10 days. You really don't want a patient to have an ET tube in much longer than that, because they can really start to develop some complications. So with your oral ET tubes, the longer you keep it in, the more risks they have of laryngeal nerve damage, other wounds. They can get wounds around their mouth where the tube is like sitting, which is why it's important for respiratory, usually like relocates it, moves it back and forth so they're not getting pressure ulcers on their lips or their tongue, and those type of things. They're at higher risk. They're at high risk for aspiration. They have a significantly decreased cough and gag reflex. So there's a lot of things that we don't that they could run into with complications the longer that you keep those ET tubes in. So usually if they get right around that week mark, they start to consider if maybe they might need a trach, something a little bit longer term, which we'll talk more about here in just a little bit. So there's that cuff, which that picture that shows the cuff there. That's the cuff, that little balloon that's inflated at the end of the tube that helps keep it in place. And it also helps prevent aspiration. So if they do have either gastric contents or just a lot of secretions or something that come back, this does help prevent some, not all, because of course they are still at risk for aspiration, like aspiration pneumonia and such. Oops, I didn't mean to do that. So that does help prevent aspiration. And what it also does, especially for patients who are being mechanically ventilated, the ventilator provides the respirations in through the tube and then down into the lungs. Well, with this cuff there, that allows the lungs to have that full inspiration, that full volume that the ventilator is giving. Whereas if that cuff is not inflated, it's going to come back out and it's not going to have its full effect. So it provides those adequate volumes that the ventilator is giving. So was somebody asking something? But I heard someone say something. So there's orotracheal or nasotracheal. Our orotracheal is going to be our oral ET tube is going to be our most common. About the only time you're going to see someone nasally intubated is severe traumas, like maybe they had a jaw wired shut, or maybe it's a like tumor or anything that is preventing that tube from actually going into the oral cavity. So very rarely are you going to see the nasotracheal intubation. After it is placed, though, we confirm it with an X-ray. We auscultate the breath sounds. There's a 5-point auscultation, upper lobes, lower lobes, and then up above the stomach, up the gastric area, to ensure there's no gurgling. Because if you hear gurgling, then you probably, the esophagus was probably intubated and not the airway. So you should be hearing both bilateral lung sounds. If you don't hear lung sounds on one side and only hear it on the other, most commonly it's the right, like main stem, that the tube goes too far down. So the tube may need to be pulled back a little bit. But our chest X-ray and our end tidal volumes are going to be the most definitive diagnosis. The end tidal CO2 reading, so that's the little, if you ever see someone get intubated, it's this little color change thing that respiratory puts on the end of the ET tube, and it detects CO2. So when they have color change, if you hear them say, yep, got color change, then that means that that CO2 detector detected CO2. So you know you're in the lungs, because the lungs are what are expelling CO2. And you know you're at least in the right air, you know, you're in the airway and not the esophagus. It's not going to tell if they're in the best location. So that's why we need our chest x-ray to determine how far the tube is going down and making sure that it's in an adequate place when you get the chest x-ray. Then after it's verified, we're going to secure it. Well, you're going to secure it even while you're waiting for it to get verified, because we don't want it to fall out. But securing with adhesive tape or commercially prepared ET tube holder. So with like, I don't know if you've been in the ICU, those like things that kind of go on their cheeks, those are those commercially prepared ET tube holders. It's the Hollister, I think is what the common brand is. So that it goes in place. And then those, I mean, they're wonderful. Like even, I don't know, 10 years ago, maybe longer, I don't know. I know when I first started, we just used tape. Like it was just the tape that went around the mouth and it wrapped around the tube and went around the back of the head. And I mean, those using the plain tape really caused a lot of damage, like a lot of injury and pressure sores. So these things are great that we have them now. And then you can easily move the tube back and forth, so you have less wounds in the mouth area as well. So they're really beneficial. So then, of course, too, once someone has an ET tube in place, you're going to be checking for breath sounds, making sure you still have proper placement just by listening to the breath sounds and everything. Moving the tube back and forth, suctioning only when needed. That it used to be like routinely they would need to get suction every 4 hours. If they have an ET tube, every 4 hours you get suction. But if there's no signs that they need suction, they're not coughing with like, they don't sound wet, like they have a lot of secretions, and you don't necessarily need to suction them, because suctioning them more frequently than necessary is just going to irritate things and can cause more damage. Then there's the pilot balloon that you want to assess to make sure the cuff is inflated. Now, you don't need to know the exact measurements of how much it's inflated with and everything, because really that is more so typically respiratory's job that does those readings of the cuff pressures and everything. But it's important that you as the bedside nurse still checks it to make sure that it is at least not overinflated or underinflated. So when you look at, I need a different picture. So this is just, this isn't even accurate because it doesn't have the pilot balloon that comes out, and there's no way to inflate that balloon without the pilot balloon. So just like your Foley catheter, how you have that port that you inflate the balloon inside the bladder, it's the same concept, except this is air. And it's like a little line that comes out from the tube. Actually, I've got it on one of the pictures of the trachs. There. This is the same thing. This is a trach, but same exact concept. You have your cuff and then your pilot balloon out here. So you always want to be checking that cuff, that pilot balloon, because this resembles what's going on down here. So if it's overinflated, you can cause necrosis if it's overinflated, because it's like they can get a pressure wound inside that airway too, inside the trachea and inside that just inside that airway. So you want to make sure it's not overinflated, causing those type of problems, because it can cause the necrosis. And then you don't want it to be underinflated, because that increases their risk of aspiration, as well as then they're not getting those adequate tidal volumes from the ventilator. So you always should at least be assessing it. I mean, just with a quick glance, I mean, obviously if that cuff is completely, or that balloon is completely deflated, then you know that this cuff is deflated. If it's like super taut, then you know that this cuff is overinflated. So those are just like simple things that you want to be monitoring for in your patient when they have an ET tube or a trach. And then keeping that resuscitation bag at the bedside at all times, just in case they become extubated, or if the ventilator stops working and you need to manually bag your patient, you just always want to make sure that bag is at the bedside at all times. And there's your ambu bag. Just an example of them. And then extubation. So with extubation, when a patient's ready to be extubated, which we'll talk about different, I think I need to rearrange these. I need to put this after weaning. But when a patient is ready to be extubated, you want to hyperoxygenate and suction that ET tube and the oral cavity just to prevent any secretions from, going back down, just keeping the airway as clear as possible. Setting them in a semi-Fowler's position, deflate the cuff, just like with a Foley. You don't want to leave that balloon inflated when you're pulling a Foley catheter out. Well, you don't want to leave that cuff inflated when you're extubating someone. They should inhale and at peak inspiration, you remove the tube, suction the airway through the tube while pulling out. Again, this is usually something that's done by respiratory, but you as a bedside nurse would still be there to assist. And then after removal, you're going to instruct them to cough, deep breathe, applying oxygen and monitoring their O2 saturation, monitoring for respiratory difficulty. So things like stridor, becoming cyanotic, mental status changes, behavior, monitoring their vital signs, making sure they're not going back into any type of respiratory distress. But hoarseness and sore throat are going to be normal. So they might sound hoarse after they've been extubated and complain of a sore throat. And I mean, they just had a tube down their throat. So of course it's not going to feel good. And one thing too, with the hoarseness and everything, when a patient is intubated, especially if they're lightly sedated, if they don't have a whole lot of sedation on and they're trying to talk to you, you really need to encourage them not to do that, because with an ET tube, it goes through the vocal cords. And the more that they try and talk around that tube, those vocal cords are just like constantly hitting that tube and can become really damaging. So you really want to provide a different form of communication for them, as far as like a whiteboard or, something that they can point at. They do sometimes, and it's so hard to, it's hard enough reading lips, but especially if they have a tube in their mouth. So if they're trying to mouth words, it just is kind of like second nature that you're trying to get something out. Some of them, that they are like trying to forcefully get words out, and you just really need to tell them to stop, because they can really damage their vocal cords doing that. So you need to tell them to stop doing that and try and find other means of communication. So then we have our tracheostomy. Our tracheostomies are usually going to be the next option if they can't get the patient off mechanical ventilation, and they need something a little bit more long-term. So it's a surgical procedure in which an opening is made into the trachea and the tube is inserted into the trachea. It's called a tracheostomy tube. So we use trachs to bypass an upper airway obstruction, permit the use of long-term ventilation, or prevent aspiration in the unconscious patient. So again, that's still going to be more so if it's longer term. They might go straight to, if they try to intubate a patient for whatever reason and they see that there's an obstructed airway, they might have to go straight to an emergent trach. But typically, most patients are going to start out with an ET tube. Once they get to that week mark, if they're not being able to get weaned off the ventilator, then they usually have the discussion as far as getting a trach placed. Sometimes it's just a matter of having the trach that then patients become more successfully weaned off the ventilator. Because if you can imagine with an ET tube that's like this long, and they're trying to do some of the work on their own when they're going through those weaning trials, it's really hard it's like breathing through a straw. But now when you have a trach that's much smaller, like this big, it makes it a lot easier for patients to breathe. So sometimes literally I've seen patients, they are not going or being unsuccessful with getting weaned off the ventilator. So they do a trach. As soon as they get the trach, literally the next day, they like pass their breathing trial with flying colors. That's a best case scenario, but it happens. So, and then in which case they would slowly downgrade the trach and eventually remove the trach altogether. But it is an option. Trachs also have less irritation and trauma to the tracheal lining, and they have less incidence, of course, of that vocal cord paralysis because it doesn't even go through the vocal cords, and it helps decrease the workload of breathing as well, as already mentioned. So here's a couple different types. This is your most common. You don't see the ones with the both cuffs very often. This is our most common, like our Shileys are pretty common trachs. And then again, here's, the cuff with the pilot balloon, the disposable inner cannula, and the obturator. So the obturator is basically your stylet. So when a patient gets an ET tube, there's a stylet in the tube that then gets removed. That's what your obturator is with your trachs. But with your obturators, you want to make sure it's at the bedside at all times, as well as a new trach, in case anything, if that trach were to come out and dislodged, it's an emergency, it's an emergency within the first 72 hours. So that obturator can be used to help guide and get that trach back in more successfully. In that first 72 hours, I mean, that trach can close off within minutes if you don't get that in quickly. So you always want to make sure you have these things at the bedside, just in case of accidental decannulation. And this would be this is a little bit older one. Almost all our trachs now have the disposable inner cannulas, which are wonderful. You just take the cannula out, throw it away, and place a new sterile one back in its place, instead of having to clean and put in the reusable cannulas. Oxygen delivery with the trach, you have your T-piece, trach collar there again. And then this is your inline suctioning, if you guys have seen it or not in the ICUs. This is typically the type of suctioning that we use when a patient is on the ventilator, because it's just, you can just suction right then and there without having to get out like all that, the sterile suctioning kit. That tube stays, it's a closed system, so it stays sterile within that plastic lining. So that way you can just suction, and it's just easy and wonderful, and the person who invented it is a genius. So interventions after a trach. Assess their respirations and their breath sounds, of course, ABGs, pulse ox, encouraging coughing and deep breathing, maintaining that semi-Fowler's to high Fowler's position, monitoring for bleeding, difficulty breathing, absence of breath sounds, and crepitus. Those can all indicate hemorrhage or pneumothorax. So after a trach has been newly placed, it is possible that there could be, if the airway, if the opening was too big, they can start to develop some of that subcutaneous emphysema, getting that air underneath the skin. So you want to be assessing for that and making sure that they don't have that. And then it could also cause a pneumothorax as well. Providing respiratory treatments as prescribed. Again, that's more respiratory's job. Suctioning as needed, hyperoxygenate before suctioning, and make sure it's set up in the room at all times. I will say in practice, you don't see, unless they are someone that is very, very sensitive to suctioning and desatting with suctioning, you rarely see patients get hyperoxygenated before suctioning. So, I mean, for the most part, it's only a few seconds. Most patients tolerate it pretty well without desatting during suctioning. But in general, we should still know that that is a process that we should hyperoxygenate before suctioning. And you always make sure you never suction going down. You always suction coming back out, and just making sure it's set up at all times. Because if they do go into distress, you want to get them suctioned quickly if they have a lot of secretions. So interventions, if they're allowed to eat, making sure that they sit up for meals and ensure that the cuff is inflated for at least 2 hours after meals to prevent aspiration. So this would obviously be the patient that's not on the ventilator anymore, because someone who's on a vent is not going to be eating yet. But, well, I shouldn't say that. There are some of the chronic vent patients, they can eat, but in your typical setting, most patients are not going to be eating still. And they could have, so that says if the tube is not capped. So the trachs can have those passy-mirror valves that allow them to speak. So generally if they have that passy-mirror valve, their cuff will be deflated to allow the passage of the air through the vocal cords so they can talk. So if you've ever had a patient with a trach or known someone with a trach, some of them have those valves. Some of them literally just put their hand over their over the end of the trach, because then it allows, instead of the air coming back out the trach, it bypasses the trach and goes up, out through their mouth, through the vocal cords, and allows them to speak. But if they're eating, that cuff should be inflated to help prevent aspiration. Again, there's that monitoring the pressures. Don't worry about those different levels. Assessing the stoma and secretions for blood or purulent drainage. Cleaning the trach site and the inner cannula according to institutional policy. So if they have a reusable inner cannula, usually what we clean it with is that half-strength hydrogen peroxide. It's been a really, really long time since I've seen someone with a reusable inner cannula. So has anybody had any? I mean, I don't know if maybe some, like in long-term care or something, maybe there's some that have had them for a lot longer and have the reusable ones. Anyone?
I think they use the disposable ones.
What's that?
In the long-term facility, they use the disposable ones.
The disposable ones, yeah. Yeah, like I said, it's been a super long time since I've seen a reusable inner cannula. So then also administering humidified oxygen, because with normal humidification process, it's bypassed in the patients with the trach. So our mouth is our normal humidification process, and that air is not going through their mouth. Obviously, it's going indirectly through the trach. So they don't have that humidification. So you might have a patient who is on room air, but they have like high flow or just like a bubbler, you know, just that's giving them that moisture. We actually, was it Chloe? I don't know. Chloe, are you in here today? I can't remember. Anyway, we had a patient just on Tuesday that had a trach and had like the high flow apparatus on, but then when we checked to see how much oxygen she was on 21%. So she was just on room air, but so she was just getting it for that humidification process. And patients on ventilators can also be on room air, because there's many other reasons that people get intubated other than just oxygen. Of course, just if they have if they are apneic or whatever, the ventilator can be weaned down as long as their oxygen levels are staying adequate. They might be on 21, 24% FiO2 and not necessarily be on a lot of oxygen on the ventilator. So you want to make sure your patient has an emergency call system. Making sure they have a call light is our big thing, but since they can't yell out or anything, you want to make sure that they do have a way to communicate and get you. So whiteboard, paper and pen is another option. These days, I feel like everybody has their iPads or their phone or something. I have patients all the time that will type it out on their phones or their iPads or something to communicate easier. And I already mentioned this, keeping that trach and the obturator at the bedside at all times in case of accidental decannulation. So again, that decannulation, now that is the entire trach, not the inner cannula, completely different. So when we say decannulation, that is the entire trach itself coming out, the whole apparatus. The inner cannula happens sometimes if you don't clip it back into place all the way and don't notice it. If they cough or something, sometimes the inner cannula can kind of shoot out. That's not an emergency. That's just the inner cannula. That just helps keep, we change it routinely so that way you don't have those secretions and stuff that dry and build up in there. But it's not going to prevent them from not breathing like the entire trach coming out would. So if the entire trach were to come out in the first 72 hours, it's an emergent and it needs to be replaced as soon as possible, because it can be very, very difficult. If it's greater than that 72 hours and you have that obturator, again, you're going to use that obturator. Now, ideally, you should have a new trach at the bedside, and you can just place that new trach. But even if it comes out some, you can place that obturator through the trach to kind of help reposition it back in, because again, that obturator is a stylet that helps guide the trach into place. Then keeping the resuscitation bag at the bedside at all times, just like we do with our ET tubes, in case for whatever reason, they need to be bagged manually, or the trach comes out and you might possibly need to bag them with that as well. Trying to think, there was something else I was going to say and I lost my train of thought. Yeah. And then we have Bipap. We're going to talk about the different vent settings with our mechanical ventilation now. And patients usually Bipap is going to be your bridge, either to prevent someone being intubated, or they might be on it after they've been extubated if they're still having a little bit of difficulty after they've been extubated. But it is just another option. And as I mentioned, you still need a physician's order for Bipap. That's definitely not one that we would just put on a patient because their stats are low. So with mechanical ventilation, it's a positive or negative pressure breathing device that can maintain ventilation and oxygen delivery for a period of time. Indications: decrease in oxygenation, increase in carbon dioxide level, persistent acidosis, or apnea that is not readily reversible. So we have two different types, our negative and our positive. Pretty sure I've never seen a negative ventilation. That would be like your iron lung. Don't routinely use those anymore. But then our positive pressure ventilators, then those are our normal ventilators. They inflate the lungs by exerting that positive pressure on the airway, pushing air in and forcing the alveoli open to expand during inspiration. So we have different types. We have time, pressure, and volume cycled. Volume cycled is our most common. It delivers a preset volume of air with each inspiration, and exhalation occurs passively. So here's all our different vent settings. I'm going to talk about each one of these a little bit, and there's all different types of mode, and the mode refers to how the breaths are delivered to the patient. The biggest thing, I mean, I'm not making respiratory therapists here, but the biggest thing with your ventilators that we as nurses need to know is which modes are giving our patient the most support. They all have their own little things, but there's certain modes that we look at that we know, okay, that patient is getting full support from the ventilator. And then there's other modes that you can look at quickly and just know, okay, they are at least doing some of the work on their own, or they're in the process of weaning off the ventilator, so that way they're doing a little bit more work. So your assist control and volume control. These are going to provide more support for your patient. Your assist control delivers at a preset volume and rate. If they breathe in between the breaths, the ventilator delivers a preset volume. So it's always going to be giving them that volume. And then your volume control is a set volume and rate, and only the ventilator gives a breath. So this is used more so with your patients with no spontaneous ventilatory effort, or maybe they're paralyzed with a neuromuscular blocking agent. And then these also, you see a lot of these too that can be used in combination. So ACVC, your assist control, volume control, is kind of like using the best of both of them for some patients. But if you know that they're on either one of these, assist control, volume controlled, or the combination of the two, the ACVC, then you know that they are pretty much not doing much on their own at all. The vent is doing most of the work for them. Then you have your SIMV, your synchronized intermittent mandatory volume. Your SIMV is, it delivers a preset volume and number of breaths per minute, but it allows the patient to breathe in between and not get a breath. So they're doing their own breathing in between in their own volumes. It can be used as a primary vent mode, or it can be used as a weaning mode. SIMVs is a pretty common one. If the patients at least have some respiratory effort, they might put them on the SIMV because at least they are still doing some of the work on their own and not solely relying on the ventilator. And as they begin to breathe more spontaneously, it decreases in the number of breaths and the patient does more work. So it's a lot more patient controlled. Then you have your pressure controlled and pressure regulated volume control. So your pressure control is when the practitioner sets the pressure and the rate. The vent gives a certain positive pressure. The volume varies due to lung compliance. We use it more so with our stiff lungs or our ARDS patients that we'll talk about here in a little bit. And it can bruise the lungs. So some of these they have to be very careful with as far as the different volumes that they're giving. And then you have your pressure regulated volume control. So that's your PRVC, another really common one too. The two that you'll see more times than not is your PRVC and your SIMV. Your PRVC is kind of the best of both worlds. They set the volume and the rate, but the vent regulates the pressure and terminates inspiration at excessive. So it adjusts to the patient's condition. Your PRVC is it's not as, what's the word I'm looking for? It's not as controlled. That's not even the word I want to look for. As the ACVC, the patient is doing a little bit, but not much at all. So it's going to be kind of more like your ACVC would be your most support from the vent, then your PRVC, and then your SIMV when they start to do more of the work on their own. But your PRVC is still going to be a primary one that they use for a fair amount of support from the ventilator. Then you have your tidal volume and your rate. So your tidal volume and your rate are a part of the different settings. Your tidal volume is the volume of air that the client receives with each breath. So it's usually 6 to 8 mils per kilo of ideal body weight. Most people will be right around 450 to 500, just because it's a bigger patient, like, 600 pounds or so. Just because you have like a bigger patient like that, they're not going to have a bigger tidal volume because it's still their ideal body weight. Your lung, just because the patient's bigger doesn't mean their lungs are bigger. So they still go by that ideal, that ideal number. And then your rate, the rate is just that's your respiratory rate. That's just what they're going to set the vent at. And it's usually between 12 to 20 breaths a minute. Your FiO2, that is the concentration of the oxygen delivered. So that is going to be the amount of oxygen they're on when you're looking at their FiO2. And then I'm not even going to talk about size. Never once have I ever charted size. I talked to a respiratory therapist. They said they don't ever chart size. So don't even worry about those. I don't think it's routinely used anymore because we have PEEP that we will talk about. So peak inspiratory pressure, then that's the pressure needed by the vent to deliver a set tidal volume at a given compliance. So monitoring this reflects changes in the compliance of the lungs and resistance in the ventilator or the client. And then our PEEP and pressure support. PEEP and pressure support can be a mode all on its own. If a patient is on a weaning trial, maybe they were on SIMV before, and now they want them to be on a trial, they might simply put them on PEEP with pressure support. So PEEP is positive end expiratory pressure, which is exerted during the expiratory phase of the ventilation, which improves oxygenation and enhances gas exchange. And helps prevent atelectasis. So what PEEP does is it essentially helps keep those alveoli open. So that way on expiration, they don't fully close. The more you have those alveoli open, the more oxygen they can take up, and the better that they can keep them oxygenated. So, and it also helps prevent atelectasis. So it just really keeps those alveoli from just completely collapsing. Usually most people, like a normal PEEP would just be about a PEEP of 5. But then when you start to get higher amounts of PEEP, it really indicates that there's a severe gas exchange disturbance. They have like stiff lungs, and they just really want to keep those alveoli as open as possible. So they'll give them a lot more PEEP. But PEEP does come with complications the higher you get, can cause barotrauma and other issues as well. So if you ever see someone who's has a lot of PEEP on their ventilator settings, you know that they're probably in a pretty significant state of respiratory failure. And typically ARDS is the most common one that we see it with. And then pressure support is that positive pressure on inspiration, eases the workload of breathing. And as I mentioned, it's often used with PEEP as a weaning mode. So basically they just have a flow and patient make their own rate and their tidal volume, but that PEEP and pressure support just gives them a little bit extra oomph on inspiration and expiration. So they're not working quite as hard without it. And then CPAP. CPAP is CPAP. We use CPAP, our normal like sleep apnea patients. But we can use CPAP on the ventilator as a weaning mode as well. It's the positive airway pressure through the entire respiratory cycle for spontaneously breathing patients. It helps keep the alveoli open as well during inspiration and prevents alveolar collapse. and it's used as a weaning mode. So they are not getting any ventilator breaths. They're doing the work on their own. Again, your CPAP is essentially like your PEEP with pressure support as well. It's the same concept. So complications, I already mentioned this. Barotrauma with high pressures or high PEEP, it can cause pneumothorax, subcutaneous emphysema, and edema, and can even cause tracheal rupture if it's severe enough. Cardiovascular complications, you have positive intrathoracic pressure that may result in decreased cardiac output, and it can also decrease blood pressure. Oh, I forgot to mention that. So one thing I just remembered, I forgot to mention with your PEEP. So PEEP we often use to with our COPD patients as well. With COPD patients, you know that they don't have their normal alveoli. They're just kind of like loose and floppy, and they have their lungs are more compliant, just being floppy like that. So, and we know that some of those things that we do to help improve their breathing, like that pursed lip breathing and everything, that is essentially what PEEP is, or that's what pursed lip breathing is, simulating PEEP. The way that it works, it just helps by doing that breathing technique, it helps keep those alveoli from fully collapsing. So PEEP you'll see with your COPDers as well as that's why we have them do that pursed lip breathing as well. Oh, where did I go? Okay, VAP, our ventilator-associated pneumonia then. Our ventilator-associated pneumonia, we know that that's a big core measure, that we have our certain indicators that we want to make sure that we're doing to prevent that from occurring. Then you have GI alterations, such as stress ulcers. That's also why we have our patients on those proton pump inhibitors, H2 receptors, making sure that they don't develop those stress ulcers. Inability to wean once they're on a ventilator, especially if they have any underlying respiratory issues. Sometimes they're a little bit harder to wean and they may not be weaned off the ventilator. Muscular deconditioning and malnutrition. So our VAP, our ventilator-associated pneumonia, it's an airway infection that can develop more than 48 hours after the patient is intubated. The hospital is responsible for the costs that accrue if someone does develop ventilator-associated pneumonia. And the mortality rate is higher for someone who has VAP as opposed to someone who doesn't develop it. As a lot of estimated cost on the hospital admission, and that's why we have our protocols to help save lives and dollars. So our protocols for our ventilator-associated pneumonia, keeping that head of bed elevated. Obviously, if the head of bed is elevated, it helps prevent the risk of aspiration that can cause a ventilator-associated pneumonia. Daily sedation, vacation, and daily assessment of readiness to extubate. Talked about this when we talked about the critical care section. The less sedation we keep someone on, the better outcomes they're going to have, the more readily they're going to be able to get extubated, and the more awake they are, the better breathing they can do, hopefully. And so we just assess that every single day, trying to do a sedation vacation and make sure they're waking up enough that they can do these weaning trials. I already talked about the peptic ulcer disease prophylaxis. Oral care is important, that we're doing that every couple of hours to prevent that bacteria in the mouth from going down into the lungs, DVT prevention and prophylaxis, and then our multidisciplinary approach to ventilator care. We do this now with all our ICU patients, so getting everyone involved with the multidisciplinary rounding to make sure all our bases are covered and that the patient is getting the best possible care with the best possible outcomes that we can give them. Then you have the Subglottic Et Tube. So this is our pretty common ET tube that we use now. It's got, so you not only do you have your little port that has your cuff, your pilot balloon with it, there's also another like tube that comes off of them that can be hooked up to some low suction. So that that port then goes down to the base of where that cuff is at and helps suck secretions out that could either one be, gastric secretions that back up, or if it's just excessive like oral secretions or something that goes back down, it helps kind of get those extra secretions out from going down into the lungs. the idea itself is great, but they don't always work the greatest because they're such a tiny, tiny tube. So if the secretions are too thick, they just don't go through that tube. They do get clogged off a lot, but I mean, it's still better than nothing. Yeah, so if you see an ET tube and they've got, those couple different ports coming from it, that's what they are, your pilot balloon and your subglottic tube. Nursing diagnoses for impaired mechanical ventilation and interventions. Just like with our cardiac monitors, you want to assess the patient first. You're not just going to treat the monitor. You're not going to treat the ventilator. You treat the patient and make sure whatever it is alarming, that it's accurate with what's going on with the patient. So assessing their vital signs, respiratory status, breathing patterns, O2 saturation, monitoring their skin color, especially nips and nail beds, monitoring their ABGs, assessing the need for suctioning and observing the type, color, and amount of secretion, and assessing the ventilator settings. So with our alarms, with our ventilators, there's different types, high pressure alarm and low pressure alarm. So depending on what the alarm is, of course, we want to troubleshoot and try and correct the problem. Our high pressure alarms are usually going to occur if there's lots of secretions and the patient needs suctioning, they're wheezing, bronchospasms, coughing, there's kinks in the tubing. Sometimes water can get in that tubing because of the humidification can get in the tubing of the ventilator that can then kind of blocks things off. Or if they're biting the tube or they're just bucking the vent, like biting, coughing, all those will be examples of high pressure alarms. The high pressure alarms are going to be caused by the ventilator not being able to give the adequate volume that it's trying to give and not giving the breath that it needs to give. If they're biting the tube, they might need their sedation increased, or bite blocks. There's like these little things that we can wrap around the tube that puts it in place to prevent them from biting down on the tube. I've seen patients literally bite through a tube before. And in that case, they need to just have the entire tube replaced, and they need a lot more sedation. Our low pressure alarms then occur more if they've become disconnected from the vent, or if there's a leak in the cuff. I've seen patients cough so hard and fight the vent so much that they've blown the cuff. And then also in that case, they need a new ET tube. They could, if they stop spontaneously breathing, if they're on one of those vent settings that is allowing them to do more work and they stop spontaneously breathing, that would be a low pressure alarm. You really get once you hear both alarms and know what they are, you know which ones are which. And your low pressure alarms are usually the ones you really want to go run into, because it can also be that they've just extubated themselves. So that's never a good feeling. If you hear this alarm suddenly going off over and over, 9 times out of 10, like sometimes the tube just comes disconnected from the ventilator and you can just pop it back on. But that when you hear those alarms, it's like, oh, please let me not walk into my patient holding their tube in their hand. Because that's never a good day. Because you can imagine too, if they're extubating themselves and pulling that tube out with that cuff in place, they can completely damage their vocal cords if that tube gets pulled through their vocal cords with that balloon still inflated. It can be very bad. And if you can't figure out the cause of the alarm, but the patient's stable and you don't see any other problems, or if there is a problem with the ventilator, you just resort to manually bagging the patient with a resuscitation bag. So if all other things can't be corrected, if all else fails, go back to old school of just bagging your patient. So our patients may need medications to help sedate them. Well, they do, most of them. Either morphine, fentanyl, propofol, lorazepam, diazepam, Precedex or dexamethasone is another common one I should add to there. And then antibiotics if they are showing signs of pneumonia, but otherwise, just because a patient's on a ventilator does not mean they're going to be on an antibiotic. But then our Pepcid or those medications, neuromuscular blocking agents, providing alternate means of communication, as we've already mentioned, repositioning the oral ET tube every 2 hours, providing adequate nutrition, monitoring them during the weaning process, If a patient's in the middle of a breathing trial, that's not the time to like go to lunch or something. You want to make sure you're there because you need to be monitoring and making sure that they're tolerating that weaning trial and not getting overworked during the process, and so that way you can assess their need to go back to their full vent settings. Turning them every 2 hours, even potentially getting them up and out of bed. And we have that those early mobilization protocols. Turning them, making sure those their secretions in their lungs aren't sitting in one place for too long, because then that increases their risk of pneumonia. And then weaning. So weaning is the withdrawal of the patient from the ventilator. Stages, gradually removing them, so that the weaning process itself, removing the tube and removing from oxygen. As I mentioned, I mean, they can be on a ventilator without oxygen, but typically they'll at least be on a little bit. And once the ventilator is removed, we'll apply oxygen and make sure that their O2 sats are staying adequate. You need to assess the weaning indices. So assessing our vital signs, of course, is very important to see if they're tolerating it. If their blood pressure skyrockets and their heart rate and their respirations and they're diaphoretic and they're just, you can tell they're struggling and tachypnic, then they're not tolerating the weaning process. I mean, that's a big indicator. You don't even need ABGs to determine that they're not tolerating it. And then another marker that we look at, and it's not on here, you don't necessarily need to know for testing purposes, but the RSBI, Rapid Shallow Breathing Index, is something that it's like a calculation on the ventilator that when they're in a breathing trial, that respiratory, then after it's completed, they can look at the ventilator settings and determine the calculations of what their RSBI is. The higher that number, the less likely it's going to be that patients are going to get extubated. The lower the number, the better. Usually, I think it's like right around 90. If they're higher than 90, they usually aren't going to be extubated. So a lot of times you'll see that physicians will want that RSBI and their vital signs and just their overall picture more so than an actual ABG. Some don't even order ABGs anymore during a weaning trial. So our different modes for weaning, as I've talked about, SIMV, pressure support with PEEP, and our CPAP. Those are going to be our primary weaning modes that you're going to look for. They can go from the ventilator to a T-piece, just like that T-piece that you saw with the trach. You can put a T-piece on the end of an ET tube. I personally have not seen that done in years, and I think it's more like torture. Essentially like, oh, let's just take them off the vent and make them breathe through this straw for the next 30 minutes. Without any support, yeah, that would be torture to me. Need early and aggressive nutritional support, increase in protein and fat with less carbohydrates, because those carbohydrates break down into CO2. Signs of weaning intolerance, which I've already mentioned these things. So increased respiratory rate, greater than 30. But also on the other end, it is sometimes patients that go on weaning trials just have no effort whatsoever and could become apneic. So of course that would obviously indicate they're not tolerating it. But those blood pressure or heart rate changes of more than 20 from baseline, their O2 sats less than 90%, they start to develop dysrhythmias, elevated ST segment. Obviously that's not a good indicator that the heart isn't getting enough oxygen. Significant decrease in those tidal volumes, labored respirations, accessory muscle use, diaphoresis, restlessness, anxiety, and of course, decreased level of consciousness. So those are all things that we are going to be looking for to see if they're tolerating the weaning process. All right, that will be a good place to stop. So let's come back at, let's do 10:25. We'll take I just like even numbers, so yeah, just a little bit more than 15 minutes. Let me pause it. Where's my pausing? Resume. And share. All right. Respiratory concepts and disorders. All right, so respiration and ventilation. We know that's our ventilation and gas exchange, all that is part of respiration. Respiration is the whole process of gas exchange between the atmospheric air and the blood and between the blood and cells of the body. It's made up of our three processes: ventilation, perfusion, and gas exchange. Ventilation is the movement of the air in and out of the lungs, and that's affected by air pressure variances, airway resistance, and compliance. With increased airway resistance, it's determined by the radius and the size of the airways, and it's any process that changes that bronchial diameter or width affects airway resistance. So there's lots of different causes of whether we have increased or decreased resistance. Asthma would be contraction of bronchial smooth muscles. That would be an example of asthma. Thickening of bronchial mucosa. That would be an example with our chronic bronchitis patients. Obstruction of the airway. I think that's pretty self-explanatory. Mucus, tumor, foreign body, those type of things. And then loss of lung elasticity. Emphysema. So again, if you think of the normal alveoli that kind of look like grapes, like a bundle of grapes, whereas emphysema, it just gets floppy and rounded, and they lose that elasticity. So they just have they just lose that elasticity with our emphysema patients. And then compliance. So compliance is the elasticity and the expandability of the lungs and thoracic structure. So compliance is how much essentially that the lungs can be like meets sort of like resistance, how easily they expand. It allows the lung to increase with the difference in pressure between the atmosphere and the thoracic cavity that causes air to flow in, and factors that determine compliance. So surface tension of the alveoli, which is normally low with the presence of surfactant, and surface tension of the connective tissues. So again, increased compliance would be our patients with emphysema, because they've lost the elasticity, they're more easily distended. So the lungs are very compliant with emphysema. Whereas decreased compliance would be like our stiff lung diseases: morbid obesity, pneumothorax, hemothorax, pleural effusion, pulmonary edema, atelectasis, pulmonary fibrosis, and ARDS. ARDS being our big one. Then we have pulmonary perfusion, which perfusion then is the actual blood flow through the pulmonary circulation. It's a low pressure system. Alveolar capillary membrane, it's ideal for diffusion because of its thinness and its large surface area. Perfusion is influenced by gravity, pulmonary artery pressure, and alveolar pressure. Gravity being a big one with our perfusion. When you think of why we turn our patients, it's not only to facilitate secretions, to keep secretions from pooling in one area if they're on one side. Obviously, we turn our patients for multiple reasons: skin integrity, but also pulmonary toileting, to make those lungs, to get those secretions up and out. But also with perfusion, when it comes to perfusion in the lungs, when you're the more dependent sides of the lungs, they're going to have more perfusion because the blood is going to be going through that area. So when you have a patient who has like maybe one lung is diseased more so than the other, like with pneumonia or maybe trauma or something like that, initially it's sometimes confusing because you think, oh, I want the good lung up so that way it can expand and get the best amount of oxygenation. But in reality, what you want to do to improve oxygenation is to put the good lung down. So turn them onto their good lung, because then that allows gravity and the perfusion and the oxygen-rich blood and stuff to go through the lungs more readily. So there's lots of different reasons that our patients need to be turned. Then we have our VQ balance, or ventilation and perfusion balance. Adequate gas exchange depends on this adequate ratio between our ventilation and our perfusion. There's an imbalance that occurs from inadequate ventilation, inadequate perfusion, or both. And imbalances cause shunting of the blood that can result in hypoxia. So there's 4 possible states in the lung. We have our normal VQ ratio, our low VQ ratio shunt, our high VQ ratio dead space, and an absent or a silent unit, absence of ventilation and perfusion, which tends to be our ARDS patients. So here is what that looks like. So the ball is our alveoli, And then the bottom part is our capillary flow. That's our perfusion. So our alveoli are our ventilation, our capillary system, our blood flow through the lungs is our perfusion. So here we have a normal ventilation perfusion ratio. That's our normal VQ ratio. Then here we have a blockage of the alveoli. Maybe it's like mucus, they have atelectasis, whatever the case may be. Now they have poor ventilation, but they still have adequate perfusion. Either way, whether it's perfusion or ventilation or perfusion, if they don't have one or the other, they're going to have decreased oxygenation. So with this one, with the collapsed alveoli, for whatever reason, this is our low VQ ratio, because low ventilation to perfusion ratio. And then here we have adequate ventilation, but poor perfusion. So you have a blockage in that capillary system that's going to the alveoli, but no problems with their alveoli themselves. So when you look at this, when you think of a blockage right here in the perfusion, but you have adequate alveoli, you have adequate ventilation, what type of disease process would this be indicative of with a high VQ ratio? Anyone? They've got good ventilation, but poor perfusion. There's a clot in the perfusion.
Embolism?
Yes, a PE. So that would be, your PE patients would be an example of a high VQ ratio, high ventilation, good ventilation, but poor perfusion. So this would be an example of a patient with a PE. And then D, again, that's that silent unit. There's problems in both areas. That's usually going to be more of our ARDS patients. So gas exchange, oxygen and carbon dioxide are transported simultaneously, whether it's dissolved in blood or combined with hemoglobin in the red blood cells. You don't need to know all these numbers with how much is dissolved and all that stuff. But the volume of oxygen physically dissolved in the plasma is measured by the partial pressure of oxygen in the arteries. So that's what our PaO2 is. Higher our PaO2, the greater the amount of oxygen is dissolved. And the amount of oxygen that combines with the hemoglobin depends on the amount of hemoglobin in the blood and the PaO2. We know that the lower hemoglobin too, the less oxygen carrying capacity we're going to have, so we can have hypoxia as a result of low hemoglobin as well. But their PaO2 can be measured up to 150, but our hemoglobin is 100% saturated. With our O2 sat, which reminds me, O2 saturation, it's SATs. It's not stats. I don't know if I've gotten on that soapbox yet in this class, but just something that drives me crazy. It's O2 sats, not stats, because it's short for saturation. So yeah, if you say it around a respiratory therapist too, it drives them crazy. Just a little sidebar there. But we know that our O2 sats are not going to be greater than 100%. So our O2 sats are always going to be 100, even though our PaO2 is 150. So that is also where the oxygen toxicity comes into play too, because just because you have a 100% O2 sat, you don't know what your PaO2 is unless you do an AVG. So they could be, and it can be crazy high and be at risk for having the oxygen toxicity. So you would want to bring down the oxygen administration, bring down your FiO2 if it's too much. So here's your oxyhemoglobin dissociation curve. And it's just kind of a visual of why it's important to keep our patients greater than 90%, keeping their PaO2 greater than, keeping it from 80 to 100 is our normal PaO2. So when you look at this, the lower their O2 saturation gets, the quicker that curve tanks. So that's why generally we like our patients to stay above 90% with their O2 saturation, because we know that as soon as they start to get less than 90, that PaO2 can start to drop significantly. When it's shifting to the right, less oxygen is being picked up, but more oxygen is being released into the tissues. When it shifts to the left, the hemoglobin has a higher affinity for oxygen. So it essentially bonds, the hemoglobin's stronger, but then less oxygen is given to the tissues. So that's where they can become hypoxic as well. Then our acid-base disturbances. So we went over our ABGs last week of how to interpret them. Today, we're just going to talk about what that picture looks like. So we're not going to go over ABGs again, but we're just going to go over the concepts of them. So our ABGs provide information about the alveolar ventilation, oxygenation, and acid-base balance. Our normal ABG values are pH 7.35 to 45, PCO2 35 to 45, our PaO2 80 to 100, and our bicarb 21 to 28. And we know that our oxygen saturation 95 to 100, but usually greater than 90 at least is usually pretty acceptable. So our pH is our indicator of our hydrogen ions. It is that's what our pH stands for. It's our parts of hydrogen. The lower the pH, the more acidic, the higher, the more alkaline, and a pH compatible with life anywhere from 6.8 to 7.8. Again, you don't need to know all these, how many parts and tenfold and all that stuff, but CO2 dissolves in water to become carbonic acid, and our lungs and our kidneys are our primary buffering system. Our lungs respond quicker than our kidneys generally do. Our lungs, can either speed up or slow down their respirations in order to either become more acidotic or more alkalotic, depending on what the problem is. So our lungs are our big buffering system under the control of the medulla, and its control the CO2 and thus carbonic acid content of the extracellular fluid. So again, the CO2 is that powerful stimulant, which is why our COPD patients who have that chronic CO2 retention don't have the same response as most people, because it kind of becomes desensitized. So the rise in the CO2 is going to stimulate respiration. With metabolic acidosis, we're going to increase our respirations to blow off that CO2. And then with metabolic alkalosis, decrease respirations to retain CO2. So it's going to do the opposite of what the problem is to try and combat it. And then our kidneys buffering system. So our kidneys regenerate bicarbonate ions, but also reabsorb them in the renal tubules. In respiratory acidosis and most cases of metabolic acidosis. So with acidosis in general, our kidneys excrete hydrogen ions and conserve bicarbonate ions. So this is what I was trying to say last week. I think it was this class that someone was asking me how it was done, and I just had a complete brain fart. It doesn't have to do with because I think the specific question last week was about like urine and stuff. It's not specifically as far as increase or decrease urine output, but what's occurring at like the cellular level in the renal tubules. There, the kidneys are excreting hydrogen ions and conserving bicarbonate ions. And then with alkalosis, they'll retain those hydrogen ions to try and make things more acidic and excrete those bicarbonate ions. It's not as quick though, it's not as quick of a turnaround as what our respiratory system can do though. So with metabolic acidosis, we have, so this, when you're looking at it this way with our Rome method, you can kind of see how that works. So when our pH is low and our bicarbonate is low, again, both those arrows are pointing the same direction. That's where we get our metabolic equal. The arrows are equal to each other. Metabolic acidosis, most commonly due to renal failure. Manifestations can be headache, confusion, drowsiness, increased respiratory rate and depth, decreased blood pressure, decreased cardiac output, dysrhythmias, shock. And if it's a slow decrease, the patient may be asymptomatic until their bicarb gets as low as 15. And then you're going to correct the underlying problem and correct the imbalance. They might need bicarbonate administered if the kidneys aren't, kicking in quick enough, because as I said, the kidney buffering system is a little bit slower of a process. Then metabolic alkalosis, you have high pH, high bicarb. So both arrows are going up, it's alkalosis. Most commonly due to vomiting or gastric secretion or gastric suctioning, so losing a lot of those particular fluids. Can also be due to medications, long-term diuretic use. Hypokalemia can produce alkalosis, and then the manifestations related to decreased calcium, respiratory depression, tachycardia, and symptoms of hypokalemia. Going to correct the underlying disorder, might give chloride to allow excretion of excess bicarbonate, restoring fluid volume with sodium solutions as well. Then with respiratory acidosis, we have a low pH and a high CO2. So the arrows are opposite. We got the respiratory opposite. Always due to a respiratory problem with inadequate excretion of CO2. With chronic respiratory acidosis, the body may compensate and they may be asymptomatic. So again, our COPDers, they might be in a chronic state of respiratory acidosis. They might have, they generally have that higher CO2, and they often have lower O2 saturations, and they're just normal and they live with it and they don't have any symptoms. But if patients have acute respiratory acidosis, you might see symptoms, suddenly increased pulse, respiratory rate, blood pressure, mental changes, feeling the fullness in the head. They have that increased risk of intracranial pressure, like we talked about last time. The higher CO2, the more vasodilation that occurs that can increase the increased ICP. And treatment is aimed at improving ventilation. Then with respiratory alkalosis, high pH, low CO2, always due to hyperventilation. So when you think, and it may not even be an actual respiratory problem. If you think of someone who's just hyperventilating, maybe it's a panic attack or something along those lines, they can throw themselves into respiratory alkalosis. They get that lightheaded, inability to concentrate, numbness, tingling, sometimes loss of consciousness, but we want to correct the cause of hyperventilation. So when someone's hyperventilating, when the example of getting that bag and blowing into the bag, so that way they're trying to reabsorb that CO2 that they're expelling to try and correct the respiratory alkalosis that they can potentially throw themselves into. So we already talked about a Rome method last week, so I'm not going to go over that again, but there's some more examples for you. The tic-tac-toe method, if that's the way that you still want to do it, that's there as well. And then we're just going to talk about specifically about our different disorders. All right, so atelectasis. So atelectasis is a collapse of the air, is a collapse or airless condition of the alveoli that's caused by hypoventilation, obstruction of the airways, or compression. Causes can be bronchial obstruction, secretions due to impaired cough mechanisms, conditions that restrict normal lung expansion on inspiration. Our post-op patients are at high risk for atelectasis. So we do those things to try and keep them from having atelectasis, making sure they're coughing, deep breathing, using those ISs, just really promoting them from preventing this atelectasis from occurring. Symptoms can be insidious, or they can be symptomatic with cough, sputum production, low-grade fever, can progress to pneumonia if it's significant enough, and then respiratory distress, anxiety, symptoms of hypoxia can occur if large areas of the lung are affected as well. So just the different mechanisms and stuff with that can result in atelectasis, that can also result, as I mentioned, in pneumonia, hypoxemia, and can, if it's significant enough, result in respiratory failure. So managing it, strategies to improve ventilation, treatment. So PEEP that we've talked about is one option if they're on the ventilator, or again, stimulating those things to stimulate PEEP, like pursed lip breathing, intermittent positive pressure breathing. Bronchoscopy might be used to remove if it's a result of obstruction. So there's an example of a bronchoscopy that could be performed to remove it. And prevention is the biggest thing, as I already mentioned, making sure we're teaching our patients that they need to be doing their IS frequently, that they need to cough, deep breathe, repositioning, getting up and walking as soon as possible. They also might have orders for like chest physiotherapy, where respiratory, kind of like beats on them to kind of open things up and improve movement of secretions. Either there's like a little handheld thing that kind of vibrates and does that chest physiotherapy, or there's the vest that they can wear that kind of shakes things up too, just different ways that they can do that. Then our pleural effusions. Pleural effusions are a collection of fluid in the pleural space, and it's usually secondary to another disease process. Fluid can be clear, bloody, or purulent. Clear fluid, exudate results from inflammation by bacteria or tumors. Transudate, plasma moves across the capillary walls. Pleural membranes that are not diseased and can caused by imbalance in hydrostatic or oncotic pressures. And then large pleural effusions can impair lung expansion and cause dyspnea. So with pleural effusions in our pleural space here, we should only have about 5 to 15 milliliters of fluid in that pleural space, just to allow for decreased friction and lung movement on inspiration and expiration. So that's like a tiny amount of fluid, just enough to essentially keep things like lubricated so our lungs don't stick to our walls. So just enough to allow that expansion. And when you have patients with disease processes that result in pleural effusions, CHF is one, can result in pulmonary edema and pleural effusions and those type of things. And then bacterial infections, lots of different reasons can result in pleural effusions. But if you ever had someone that has had a thoracentesis and they have like 800 milliliters of fluid removed or 1200, something crazy like that. I mean, like, just imagine the amount of pressure that it can put on the lungs and why they have such a hard time breathing. It would be like a liter bag of IV fluid sitting right here pushing up against the lungs. So it's important that we get it corrected and figure out the underlying problem. So treating the underlying cause, preventing recurrence and relieving respiratory compromise and pain. Thoracentesis and with analysis of the pleural fluid. So after they do the thoracentesis, they're going to send the fluid to lab to assess it and see what is possibly the problem. Pleurodesis, I haven't seen that done in a while. It's essentially it's like a talc powder that goes into that cavity to kind of like absorb the fluid. And then chest tube, especially for recurrence, maybe they have a thoracentesis and remove the fluid. But then it comes back again within a few days. So they might just place a chest tube to allow the continuous drainage of it while they try and treat the underlying cause that's causing it to occur. Some patients have chronic pleural effusions, especially like our CHFers, cancer, something that can cause those effusions to continually come back. They can place a Pleurex drain, which is essentially a chest tube that they can go home with, much smaller, and it can disconnect and reconnect to the drain system itself, so that can be done at home. So every few days they can connect the canister, drain the fluid, and then go about their day, instead of having to constantly be coming into the hospital and having a needle thoracentesis aspiration done. So those are some benefits for nursing. We do assist with thoracentesis. If they have a chest tube in place, we're going to monitor our chest tube and of course assess for their respiratory status and pain management as well. Empyema is essentially pleural effusions, but is infectious in nature and causes an accumulation of thick purulent fluid in that pleural space. Often has fibrin development and it's loculated or it's walled off. So whereas like your typical pleural effusions just kind of can be in that entire pleural space, your empyema, that like area of like bacteria and infection is just it's walled off. It says walled off, that's what it is. So it they often are very, very sick because it's an infectious process that can make them super, super sick. Often a complication of bacterial pneumonia or lung abscesses. So they spike high fevers. They need to be on strong antibiotics. Oftentimes they have chest tubes to facilitate the drainage of that area. They may or may not do a thoracotomy. Usually they're going to wait to start antibiotics and stuff before they would like go in and open it up and remove that area of empyema, because you don't want it to spread and cause worsening infection and sepsis. So monitoring them closely for those signs of sepsis is really important with fevers and their vital signs and everything, their white counts, all those things. Then we have our pulmonary embolism, which is a life-threatening thrombus that becomes dislodged and lodges in the pulmonary vessels. There's an obstruction of the blood flow, decreased systemic oxygenation, pulmonary tissue hypoxia, and then can result in potential death. The symptoms are going to depend on the size of the thrombus and the area occluded. So of course, the bigger the PE, the more problems a patient could potentially have. And then in diagnosis, excuse me. Hang on. Diagnosing RPE. ABGs are usually going to be in respiratory acidosis, but also our main definitive tool is our spiral CT or our CT with contrast. But we know those contraindications, those things that we shouldn't have a CT with contrast for, like our renal patients, if they have an allergy, those type of things. But VQ scan is another option, or ventilation perfusion scan. It will determine whether the patient's probability of having a PE. The problem with a VQ scan, the nice thing about it is it doesn't use dye. So maybe your kidney patients or someone who can't have the contrast could have the VQ scan, but it's a long test. Like it takes about an hour and they have to be lying flat and hold still. So you can imagine someone who has a PE, and if they are anxious or having respiratory difficulty or anything, they're likely not going to tolerate the VQ scan, but it is at least a potential option. Chest X-ray is not going to particularly diagnose our PE, but it'll help rule out other processes. And then a pulmonary angiography is another possibility as well. There's a picture of what a significant PE can look like. And then treatment. You're going to stabilize the cardiopulmonary system, dissolve the clots, and prevent further clots from forming. So dissolving the clots, they might go in, they're not going to typically use systemic like TPA for a patient with a PE, but they might go in with an arteriogram and either remove the clot, have an embolectomy if they can get to it, or like dissolve the clot specifically with like a clot buster, like a localized one, not a systemic one, to try and dissolve the clot. And then of course they're going to be on heparin to prevent further clot formation from occurring. And if they potentially may not be able to be on blood thinners, an inferior vena cava filter is another possibility, an IVC filter. So that filter is essentially like an umbrella that goes into the inferior vena cava that prevents clots that come from the legs to go to the lungs. Because as we've already discussed, usually our DVTs are what's going to cause our PEs, because legs, lungs, heart, head. So that IVC filter, maybe they're an elderly patient who has a lot of falls that maybe shouldn't be on blood thinners, or a young patient in sports or something where you don't necessarily want them to be on blood thinners to prevent the PEs from recurring, but they might place that IVC filter as an option to prevent it. So discharge teaching, activity, bleeding precautions, follow-up. Activity, making sure that they're, that if they're being discharged on blood thinners, that they're careful with their activities and that they're at increased risk for bleeding. And if they do have significant like shortness of breath or anything with activity, that they need to not overdo it and just take frequent rest periods. Bleeding precautions, if they're on the blood thinners, obviously they need to be made aware of their bleeding precautions, and things that they need, other things that they need to be aware of as far as if they're on Coumadin, making sure that they're not eating those foods that are high in vitamin K that can affect it, or not taking like aspirin or anything in additional unless specifically directed by their doctor, and making sure they're taking their follow-up, maintaining their follow-up appointments, whether they need to get their lab values continually checked to make sure they're at therapeutic levels and those type of things. So acute respiratory failure. Acute respiratory failure then is sudden and life-threatening deterioration of the gas exchange function of the lung, cannot provide oxygen or ventilation. Our common processes that often result in respiratory failure: pneumonia, ARDS, heart failure, pulmonary embolism, or restrictive lung disease. With ventilatory failure, it can be a result of CNS impairment, which would be like our drug overdose, head trauma, infection, sleep apnea, hemorrhage, neuromuscular dysfunction, ALS, Guillain-Barré syndrome, myasthenia gravis, musculoskeletal dysfunctions, or chest trauma, kyphoscoliosis, malnutrition, pulmonary dysfunction, or COPD, asthma, cystic fibrosis, I can't talk, cystic fibrosis. So this, of course, is not an extensive list, but just some examples. And then post-op factors, effects of anesthesia, analgesic, and sedatives can cause hypoventilation that can cause patients to go into respiratory failure. Early manifestations, again, that restlessness is often a common early sign: fatigue, headache, dyspnea, air hunger, tachycardia, increased blood pressure. And then as it progresses, confusion, lethargy, tachycardia, tachypnea, central cyanosis, diaphoresis, and eventually respiratory arrest. Our diagnostic tests to help and determine the problem. Cardiac enzymes and EKG if it is a potential for MI suspected, and as well as our BNP if it's CHF related. It'll help determine whether or not it's a respiratory problem or a cardiac problem. Correct the underlying cause, restore adequate gas exchange to the lungs. So they might potentially need high flow oxygen, Bipap, especially useful with our CHF exacerbation. And then intubation and mechanical ventilation if it's severe enough, pneumonia, ARDS, severe chest trauma, antibiotics for pneumonia, our DVT prophylaxis and stress ulcer prophylaxis to hopefully prevent, either PE or aspiration to prevent respiratory failure. Supportive care, nutrition, hydration, oral care, turning that we've mentioned, diuretics for cases of pulmonary edema. And then we have our ARDS, our acute respiratory distress syndrome. ARDS is a severe form of acute lung injury, which is characterized by sudden progressive pulmonary edema, increasing bilateral lung infiltrates on the chest x-ray, and hypoxemia that's refractory to oxygen therapy. And they have decreased lung compliance, so they have those stiff lungs. The biggest indicator though is that hypoxemia that's refractory to oxygen therapy. It's like you just keep giving them oxygen and they are not responding. They remain hypoxic. But if we go back to thinking about our ventilation and perfusion, they just have like that silent unit. So they don't, you're trying to do measures to improve perfusion, you're trying to do measures to improve ventilation, but there's just like nothing there that's working, and they just have that silent unit. So they are just refractory to any oxygen therapy that you're trying to give them. The mortality rate is high, 25 to 58%, with sepsis being a major cause of death. Etiological risk factors related to ARDS: aspiration, smoke inhalation, DIC, heart bypass, massive transfusions, shock, localized infection, pneumonia, sepsis, trauma, surgeries, and fat or air embolism. I mean, like anything can cause a patient to go into ARDS essentially. So here with your pathophys, you have your acute lung injury, which causes the initiation of that inflammatory response. There's a release of those mediators, causes increased capillary permeability. They can go into, the fluid can accumulate in the lungs, decrease airway diameter, injury to the pulmonary vasculature, and it just causes a perfect storm of the lungs just not working, and can result in the alveolar hypoventilation, intrapulmonary shunting that then results in the hypoxemia. It usually is an acute event that happens over 4 to 48 hours. It can resemble hemodynamic pulmonary edema, but it's non-cardiac in origin. So again, that's, they have like that chest wide out that looks like it could potentially be pulmonary edema, but checking for the BNP to make sure it's not related to, that it's not cardiac in origin. And then that arterial hypoxemia doesn't respond to oxygen. The chest x-rays worsen and it progresses to fibrosing alveolitis with persistent severe hypoxemia, increased alveolar dead space. So initially ventilation to alveoli, but there's poor perfusion, and then decreased pulmonary compliance. So they have those stiff lungs. I already mentioned distinguishing between heart failure and pulmonary edema. They might do a TEE to check the heart as well, possibly a pulmonary artery catheterization. Usually they're going to be too unstable for these type of things, but they're a potential. ABGs are going to show the low PaO2 despite the oxygen. The CO2 initially might be low, but then increases with fatigue and the pH drops and results in respiratory acidosis. Chest X-ray changes happen after 24 hours, usually initially just patchy interstitial infiltrates, and then it progresses to that full whiteout appearance. So here's your normal lungs, your chest X-ray, and this is ours. And this is actually better than some I've even seen. I've literally seen some that this is, I mean, there's like no black whatsoever, and they're just completely whited out with no air movement whatsoever. Couple of videos. I'm going to show this rotoprone one. If you've never seen one of these beds before, they're pretty fancy. So here is your patient. That's their face right there with the ET tube. It's proning the patient, and it's allowing for a couple of different things. So we know that turning is important for our patients to facilitate drainage, for one thing, to help move those secretions and get them out. Well, that's one thing that proning does. It helps facilitate that drainage. And so you can see this pad underneath this patient, because generally when someone is being in one of these beds, those secretions, I mean, they're just going to start coming out. Well, at least they should. That's the goal. So they get a lot of secretions down there. So that's that pad there to catch some of those secretions. But also using gravity, using the non-dependent parts of the lungs that are less damaged also helps facilitate that perfusion by using gravity and proning the patient as well. It helps improve that ventilation perfusion model and helps decrease shunting in those more dependent areas, the posterior parts of the lung. So proning is really, really beneficial. The sooner that you can start a patient who's in ARDS on proning, the better. So right now with COVID, these patients often go into ARDS, and they quit even using these beds right now because they have so many patients that they're proning. So they're just manually proning a lot of these patients, just using manpower to flip the patients over onto their bellies, and then just turning them normally, like our every 2-hour turning like we normally do. Let me stop that. Where'd it go? And the beds are expensive, and you have to special order them, and it takes sometimes several hours to even get them to come. When your patient's in ARDS, time matters. So sometimes when it takes a long time to get these beds, by the time they get there, sometimes it's too late. So I haven't seen one of these beds in a while because they're proning so many patients that it's not even worth ordering these beds right now. And they're it's time consuming to manually prone your patients, but it's also, these patients usually are one-on-one because the beds are so advanced and require like training, and you don't want patients to become, tubes to get dislodged and stuff like that while they're turning the patients and everything. So it's been a little while since I've seen one, but when you were only proning 1 or 2 patients on a floor, if at all, they are beneficial in certain situations. But unfortunately right now it's just, we don't have time for them. And then, so managing ARDS, treating the underlying disorder, aggressive treatment, antibiotics for sepsis, because it's usually also result in sepsis or infection, corticosteroids to help with inflammation, intubation and mechanical ventilation. So they might have lower tidal volumes, but they have high. So again, these patients in ARDS that have those stiff lungs and decrease in compliance, they'll use that PEEP to help keep the alveoli open to help facilitate as much uptake of oxygen as possible. They might use nitrous oxide for pulmonary vasodilation and bronchodilation. So again, improving the perfusion, trying to help with the oxygen uptake with that nitrous oxide. So if you ever see a patient with one of those, like, it looks like a ginormous oxygen tank, it's actually nitrous oxide. So that the patient's receiving that nitrous oxide through that. They have high nutritional support needs, and maintaining their hemodynamic stability. So dopamine, dobutamine, need to be careful with your IV fluids because again, with the pulmonary edema and everything, it can worsen if you're giving too many IV fluids. Preventing complications, complete respiratory failure, DIC, and dysrhythmias. So positioning, as I've already started to talk about, to improve ventilation, enhance drainage and secretions. The proning position can help improve that oxygenation. And ventilator care, respiratory assessment, sedation to decrease anxiety. So patients that are on these beds, especially on these prone, rotoprone beds, but even patients being prone in general, sometimes need additional sedation and even potentially paralyzed, because as those secretions start to move and trying to get them up and out, they cough a lot, and sometimes they can really fight the vent. So sometimes they need paralyzed just in order to promote rest and allow the lungs to heal. And then emotional support for the patient and family, especially the family coming in, seeing them in this state, of course, can be very traumatizing for family. But when you're proning your patients, you know it's successful if their oxygen increases by at least 10% within the first 30 minutes. So the idea is that it helps improve their oxygenation, and you don't want to run into anything that's causing them to be unstable. So once you prone your patient, some things that you need to look for to see if they're going to tolerate it. Of course, their vital signs. If their O2 sats drop instead of rise, that would be an indicator that they're not going to tolerate the prone positioning. But also tachypnea, they can become hypotensive. Just monitoring their vital signs to see if they're tolerating the prone positioning. But the increase in sedations and the coughing, it would not be a contraindication for proning, because that's what they'll likely do that, but that's what you want them to do. You want those secretions to get out. You might need to increase the sedation so they're not coughing too much. And then the other thing too is breakdown. Their facial swelling and breakdown is a big thing with proning, because again, they're essentially on their face, and they have like special pillow. Well, if they're on the bed, there's like special like face holder in the beds, but now with manually proning, there's like special pillows to put the patient's like face in, but their face is dependent. So sometimes they just don't even look like the same person, and they just swell and lips crack, and they can get pressure sores from being on their face. So it's a complication, but not a contraindication, because of course, improving their respiratory function is a higher priority than skin breakdown at this time. So the things that would actually contraindicate from proning would be things that they're unstable as far as their vital signs and their O2 saturation, those type of things. All right. Oop, I didn't mean to stop share. And to go to the next one. Come on. Okay, so now our chest injuries, chest tubes, all that stuff we're going to talk about. Thoracic surgeries, going to go over that. All right, so we're going to go over some of the different kind of chest injuries and traumas and stuff like that can cause or have facilitate the need for thoracic surgery and or chest tubes. And then we're going to talk about chest tubes. So flail chest usually occurs from blunt trauma associated with accidents that may result in hemothorax and rib fractures. So your flail chest often occurs when there's lots of rib fractures. And then there's a loose segment of the chest wall that becomes paradoxical to the expansion and contraction of the rest of the chest. So with your flail chest, you have the biggest indicator that you have flail chest is that paradoxical respirations, where they have the inward movement of the segment of the thorax during inspiration and outward movement during expiration. So it's like the opposite of what normally occurs. Because we know when you inspire, when you take deep breaths, your chest should expand. Well, in those areas where that flail chest is occurring, instead it's like kind of being like sucked in kind of. So that's the biggest indicator of determining flail chest. And then also severe chest pain, dyspnea, cyanosis, tachycardia, hypotension, tachypnea, shallow respiration, diminished breath sounds. So all those things that we're going to be looking for because they can go into respiratory distress. There's a picture, kind of like an image of what that paradoxical breathing can look like. And again, so interventions, we're going to place the patient in Fowler's position, administer humidified oxygen, monitoring for increased respiratory distress, encouraging deep breathing and coughing because it's going to hurt and be hard, but we don't want to worsen things by atelectasis and stuff developing. Administering pain meds, maintaining bed rest, limiting activity to reduce their oxygen demands. And they could potentially wind up intubated and need mechanical ventilation with PEEP to help improve that the alveoli and keep them open. Then a pneumothorax. Pneumothorax is the accumulation of atmospheric air in the pleural space, which results in a rise in intrathoracic pressure and reduced vital capacity. There's different types. Spontaneous, it occurs with the rupture of the pulmonary bleb, so that it just the lung areas can just essentially rupture themselves and cause a pneumothorax for air to be in that space. And open pneumothorax, as the name implies, it's open. So there's an opening through the chest wall. It allows entrance of positive atmospheric air. And these would be like your sucking chest wounds. So you want to try and occlude that as soon as possible to prevent more air from going into that cavity that can't then escape and really puts force on the lung. Tension pneumothorax, air enters the pleural space from a lacerated lung or opening chest wall, and the air cannot escape, and the lung collapses. And so they'll have a mediastinal shift. So they could have a tension pneumothorax with an open pneumothorax if it's open, but then for whatever reason it can't escape, it's going to result in the tension pneumothorax. So with the tension pneumothorax, they're going to have that tracheal deviation to the opposite side, to the unaffected side. So that trachea will kind of deviate away from the side that actually has the pneumothorax in it, the tension pneumo. Pneumothorax in general is going to depend on the size and cause. They might have sudden pain and it's pleuritic in nature, so it hurts more with breathing, with the breathing cycle. Hypotension, tachycardia, diaphoresis, central cyanosis, and subcutaneous emphysema. So they'll have that like Rice Krispies kind of like under the skin that you're going to assess for. And they're going to have diminished breath sounds on that side as well that the pneumothorax is in. So managing treatment of the sucking chest room, obviously that's an emergency. Could potentially need a needle aspiration of the tension pneumothorax, chest tube placement, analgesics for chest pain, and anxiety medications to decrease their anxiety as well. Lung cancer, so you don't need to know all the real specifics of lung cancer. Mainly the thoracic surgeries that we're going to discuss often are a result of lung cancer. So whether they get a lobectomy or a pneumonectomy or thoracotomy, sometimes those are just a result of removing the lung cancer. Lung cancer that is classified as a small cell lung cancer and non-small cell lung cancer. Overall survival rate is only about 16%. In some risk factors, exposure to inhaled substances that cause chronic tissue irritation. We know smoking is a big thing with lung cancer, but secondhand, third-hand smoke, asbestos, beryllium, chromium, coal, cobalt, tar, nickel, and air pollution, etc. All those things can be risk factors for developing lung cancer. Interventions. Often it can be palliative if it's already a late stage at diagnosis. Our non-surgical management, all things that we talked about last week, and then our surgical management, which we'll talk about these different things. So our different types of thoracic surgeries, we have your pneumonectomy, which is removal of the entire lung. With a pneumonectomy, some considerations with that is you don't want to, when I talked about before about with repositioning the patient, if you're trying to improve oxygenation, you want to turn your patient to their good lung to use gravity to help with perfusion. If through the lung. But with a pneumonectomy, you want to actually turn to the absent lung to facilitate drainage and stuff in that cavity to prevent tracheal deviation. So you actually, with a pneumonectomy, you actually do want to turn them to their operative side. Lobectomy then is just removal of a lobe of the lung. And segmentectomy, segment resection, single segment of the lobe is removed. Wedge resection is removal of a wedge of tissue without regard to those intersegmental planes. They might do this if there's like an area, like a node that needs to be removed, instead of removing an entire segment, they just remove that portion with disregard to the segments. Lung volume reduction, so that's removal of 20 to 30% of the patient's lung through an incision or through a video thoracoscopy. This is sometimes used with more like end-stage emphysema patients. And then your video-assisted thoracoscopy is an endoscopic procedure that allows view into the thorax without making a large incision. So they sometimes will do a VAT for some of these surgeries without having to make a really large incision, which it just, instead of doing like an open thoracotomy, they might do a video-assisted thoracotomy. So the objectives: ascertain the patient's functional reserve, determine whether they're likely to survive, and if the patient is in optimal condition for surgery. So obtaining a thorough assessment in H&P, test their pulmonary function test, ABGs, exercise tolerance, bronchoscopy, chest X-ray, MRI, all the lab levels, just doing a thorough assessment to determine whether or not they'll fare well after surgery. Pre-op, making sure you're discussing the post-op course, so making sure they understand what they need to do post-op as far as deep breathing exercises, IS, pursed lip breathing, diaphragmatic breathing, that they're likely going to have chest tubes, they might need blood products, might need to be on the ventilator for a period of time, just so they're well educated beforehand. And different nursing diagnoses. And then post-op care, oxygen, mechanical ventilation, and just oxygen use in general as well, but checking their vital signs, O2 sats, checking them frequently. They'll have a reduction in the lung capacity that requires physiological adjustment, so they have to be made aware of that as well. You might give lower fluids to prevent fluid overload and pulmonary edema. Positioning, of course, is going to be important, keeping their head of bed elevated, all those things that we're going to do to try and prevent lung complications in general. We're going to do the same things for our post-op thoracic surgery patients. I already mentioned this about the pneumonectomy. You're going to turn them from their back to their operative side and not the unoperative side. Lobectomy, doesn't matter which way you turn them. Segmental resection, they're usually not turned on the operative side, but again, it's your pneumonectomy, your full pneumonectomy patients that you're going to be more diligent about turning to that operative side. Pain management, epidural, PCA. You don't want to over sedate them, so that way it depresses their cough and ability to take deep breaths, but you need to give them enough pain medication that they're also able to do those things. Chest tube drainage system management, we're going to be watching those closely. Maintaining fluid volume and nutrition, promoting mobility and shoulder exercises. So especially if they've had a complete open thoracotomy, those shoulder muscles are affected, so they need to make sure that they're utilizing those muscles and doing those exercises to prevent complications. And they usually want them up and out of bed within 8 to 12 hours. Potential complications, of course, respiratory failure, dysrhythmias, pneumothorax, bronchial pleural fistula, hemorrhage, shock, atelectasis, infection. Signs of complications, cyanosis, dyspnea, chest pain, same things, looking for signs of respiratory distress and hypoxia. Assessing the dressing for bleeding, coughing and deep breathing, splinting exercise, or teaching them how to splint when they're coughing, so that way it doesn't have as much pain, so that they really can cough effectively. And preventing infection, those things that we do to prevent infection, good hand hygiene, monitoring the dressing, those things. There are some ways that you can teach your patient or assist your patient with splinting when they're coughing. And it's important, especially after thoracic surgeries, that you know that you're looking for signs of respiratory distress or hypoxia, which restlessness usually is a big indicator, an early sign, but you got to make sure you're not confusing that with their restlessness that could be just potentially caused by pain. So maintaining their adequate pain relief, but still monitoring for signs of dyspnea, restlessness, increased respirations, high blood pressure, tachycardia, that can all be signs of impending respiratory insufficiency. Making sure we're monitoring their pulse oximeter, and again, differentiating those causes that could be caused by, or things that could be causing restlessness. All right, and then chest tubes. So our chest tubes, it's important to assess our chest tubes. Oh, good, we still have a good amount of time. Our chest tubes are inserted into the pleural space to drain fluid, blood, or air and reestablish that negative pressure in the lungs. That helps facilitate that lung expansion and restore normal intrapleural pressure. There's 3 different types. We have our traditional water seal with wet suction, or our dry suction with water seal, and just plain dry suction. There's a video here if you feel like watching it. Just kind of explains how chest tubes kind of work in general. So it's there if you choose to watch it. So you need to know the different chest tube chambers that you're looking at. So which chamber you're looking at for what. You have your drainage collection chamber, which that is where the chest tube connects to the patient. And that's where the drainage is collecting into that those calibrated columns in the chamber. So that's where you're going to assess to see how much drainage they're having out, what it looks like, those type of things. Then you have your water seal chamber. Your water seal chamber is the tip of the tube. So the patient, it's connected to the patient, and then it comes down into your atrium system. And there is a chamber that has water in it that keeps essentially that tip underwater, that allows fluid and air to drain from the pleural space, but prevents air from entering back into the pleural space. In this chamber, the water should oscillate or tidal, which is basically, it can move up and down with the client inhaling or exhaling, but it should not be bubbling. So in the water seal chamber, just normal slight tidling is normal, but excessive bubbling indicates there's an air leak. So if there's an air leak, it's either the chest tubes become disconnected, there is a break in the system, it's come completely out, or in situations with pneumothorax, they might have bubbling in that chamber as that pneumothorax is healing, as that air is leaving that pleural space. That can cause some bubbling in that water seal chamber. But if they don't have a pneumothorax, they should not have bubbling in that water seal chamber. So this is an example of kind of how the chest tube drainage system works. This is actually what they used to use for chest tubes. And I swear I am not that old, but I actually had a patient with glass chest tubes once when I was travel nursing, because the doctor that placed the chest tubes and the patient that had surgery was like 90 and refused to use like the newer systems and was still using glass chest tubes. So I actually got to see this in action, the way that they used to do chest tubes. It was interesting, but I couldn't believe they were letting him do it still. So here's our normal collection system. Atrium's a pretty common brand, but this is our atrium system. Here is where this D chamber here is where your collection system is. So that's where your drainage is going. You mark it like every shift. You don't need to change it until it's full, but this is where you're going to monitor for your drainage. And then A here, this would be, so this is a wet suction water seal drainage system. So here's your water seal chamber, I'm sorry, your suction chamber in chamber A here. So depending on what the physician orders as far as the amount of suction they want, this determines how much you fill it up in this section. You can't see it in this picture really, but it'll determine like what line you put it at, determines like if it's -10 or -20 centimeter suction. And then up here is where it then goes and connects to the wall, because you still need your wall for the suction, but this this is the gauge about how much suction it will actually allow to be exerted. So in this chamber, when you have a wet suction and it's sucking from here, this chamber will have bubbling. They'll have constant bubbling in this chamber because that's the suction control chamber. But in this chamber down here in chamber C, that is your water seal chamber. So that's where it gives that seal so that way air doesn't go back into the pleural space. And that is the chamber, your water seal chamber is where you're going to be assessing for bubbling, because there shouldn't be bubbling in that chamber if they don't have a pneumothorax. If it's just, you know, for a hemothorax or something, and or a pneumothorax that's resolved, they should not have bubbling in that water seal chamber. If they do, that's when you got to start checking your connections and making sure everything is okay. Otherwise, you should just feel like a slight titling in that chamber. So here's your dry suction water seal. This is the most common one that you're going to see. So you still have the same chamber D with your drainage collection system over here. And then here in C is still your water seal chamber that you're going to assess for your air leak. And then here A is your dry suction. So instead of it being controlled, like putting the water in to control the level of suction, you literally just dial and put the whatever the order is for the dry suction. And then this has this little accordion here that helps you know that the suction has been activated. So again, it still just goes to the wall suction, but this manages the amount of suction that is being exerted. Then you have your dry suction dry seal. Same thing as your dry suction water seal, your wet seal, but you just don't put the water in it. I honestly don't hardly ever see them do a dry seal. And I don't particularly know why they would choose a dry seal over a water seal. You would think you would always want the water seal just to prevent the, to allow just what it is, the water seal, so that way it doesn't allow for air to go back into the pleural space, but it is an option. All right, so I already talked about this, but the suction control chamber helps provide that suction, which can be controlled and prevent that negative pressure to the chest, filled with various levels of water to achieve that desired level of suction. And there should be that gentle bubbling in that chamber if it's a wet suction. That does not indicate there's an air leak. That we're going to look at our actual water seal chamber to look for our air leak. And some patients don't even need suction. The physician may just say, keep it to water seal. So you just turn the suction off and you don't necessarily need suction. It's just going to naturally drain by gravity. So when you're assessing your chest tubes, you're going to assess the insertion site for redness, pain, infection, crepitus, and making sure it's an occlusive dressing. Usually we'll put like Vaseline gauze wrapped around the tube at the site itself, just to prevent any air from going into that space. And then you have the occlusive dressing over the top. The drainage system should always be below chest level. Watch for dependent loops, making sure all the connections are taped so things don't become accidentally disconnected. And you're going to document the amount and color of the drainage every 8 hours or more frequently, depending on your setting. But you're going to notify the physician if they start to have more than, especially more than 100 mils an hour, or if it becomes bright red or it just increases suddenly. You want to notify the physician because that indicates that there is some active bleeding going on. So you're going to monitor the water seal chamber for fluctuations, and again, no continuous bubbling because that can indicate an air leak. And then can there be intermittent bubbling at any time? I've already mentioned that. With the pneumothorax, there could be bubbling in the air chamber, water seal chamber if they have a pneumothorax. And the suction control chamber should have gentle bubbling if it's a wet seal or wet suction, and then change their position frequently to promote drainage and ventilation. And we don't ever want to strip or milk a chest tube unless it's specifically directed by the physician and if the policy allows. So generally stripping, we definitely don't want to do. I believe I talked about this when I talked briefly about chest tubes with our post-op CAB patients. But stripping, just really, if there's like clots or something in the tubing and you want to strip those out, it really exerts a crazy amount of suction that then can cause increased bleeding that we don't want to do. Milking, I mean, most places you might do a little bit of milking, but milking the chest tube, kind of like what we do with our Foley catheters, to facilitate drainage, also does kind of promote a little bit of additional suction as you're doing that. So really, unless the policy allows you want to try and avoid doing milking your chest tubes as well. You don't ever want to clamp the chest tube without a specific order. Administer pain medications as prescribed. Encourage coughing and deep breathing. Assessing vital signs, respiratory status at least every 4 hours, if not more. And you always want to keep 2 covered hemostats or clamps at the bedside at all time, a bottle of sterile water, and an occlusive dressing. You always want to keep those things at the bedside in case something, just to troubleshoot if something either becomes dislodged or becomes disconnected and you can't get it reconnected right away. You might need to clamp it just to prevent air from going back into that pleural space. If it's far enough away from the patient, you can put the end of the tube in a bottle of sterile water, because that essentially gives you your water seal. So that way then also air doesn't go back up into the space and cause that tension pneumo. And then if it comes completely dislodged, if they pull it out or something like that, you want to have an occlusive dressing that you can put over the site, again, just to prevent any air from going into the chest wall. So I already mentioned that, immersing it into the sterile water. So the occlusive dressing, if it comes completely removed, you put the occlusive dressing on, but only tape it on 3 sides. So that way it allows for air to escape, but then it kind of flaps back down and reduces that risk of that tension pneumothorax. And if it separates, you just want to have them exhale as much as possible, cleanse the tip, and reconnect the tubing. And hopefully, and likely you're going to have to get a chest x-ray to make sure there wasn't any additional problems that occurred afterwards. So thoracic surgery, then home care, signs and symptoms to report to the doctor: changes in their respiratory status, the amount of color and sputum, bleeding, drainage from the surgical incision or the chest tube exit sites once they've been removed, increase in pain, using local heat, oral analgesics to relieve intercostal pain, alternate walking and other activities with frequent rest periods. They're going to have weakness and fatigue within the first few weeks, but excessive shortness of breath and difficulty breathing is not normal, and they should be reporting that. Performing breathing exercises several times a day for the first few weeks at home. Usually they'll go home with their IS so they can work on it at home. Avoiding lifting more than 20 pounds until complete healing has taken place. The chest muscles and the incision may be weaker than normal for the first 3 to 6 months after surgery, to be expected. Walking a moderate distance and gradually increasing. Shoulder and arm exercises, again, about 5 times daily, just especially after those thoracotomy surgeries, those big surgeries where they've had to do a lot extensive amount of removing that shoulder, like if they had to go in and those shoulder muscles. And then immediately stop any activity that causes undue fatigue, increased shortness of breath or chest pain, as I mentioned. Avoiding bronchial irritants. Yeah, they should probably stop smoking. Avoiding other foods, or others with colds or lung infections, making sure they get their annual flu vaccine, stop smoking, report follow-up care with the surgeon. All right. And that is it. I went over yesterday, but we had I think about a solid 10 or 15 minute talk because a couple of people had COVID and we're talking about it yesterday. So I'm sure that's why we went over yesterday. But any questions or comments or